welcome to the stream of Learning from Patients. We're really excited to have Julia Holden now talking about how we aim for a fabulous patient experience in the current context. I'd just like to say a little bit of an apology. I think in the programme your title was a bit wrong. So it's now you're an independent healthcare consultant and volunteer. Is it Walsall Hospital, Julia?
Yeah, I'm part of their contingency volunteering force. Not currently going in, but they basically can mobilise us all at very short notice. So we're sort of standing by at the moment.
Fantastic. So we're going to hear a little bit more about how we can aim for fabulous patient experience in the current context, which is so important. So over to you.
Okay, lovely. And it was absolutely lovely to hear the news from Royal Free. Bit of a fraud, because obviously I'm not leading on patient experience in a trust or in an organisation anymore, but it's absolutely my passion, and I'm hoping that it comes across when I talk to you here today. So thanks for inviting me, guys. So, yeah, fabulous patient experience. It's something absolutely to aim for, but very tricky in the current context. Certainly consistently do that. So we know that the NHS response to COVID-19 has brought some real benefits as well as a whole host of challenges. And as we reflect on the impact of these changes, it's more important than ever to see these through the eyes of patients. And certainly the last presenter was saying, talking about the moves that they were making to ensure that that voice of patients continues to be influential in their organisation. That's absolutely so important. Really, unless we do that, we aren't going to be able to make the right decisions about the things that we need to make sure we sustain, because there are so many changes that have been made that we will have to sustain because the current situation hasn't changed. So why am I talking about this? So why is this important to me? So I'm pretty old. So I've been working for the NHS. Well, I worked for the NHS for nearly 40 years, which is pretty scary. And mainly in clinical, but latterly in fairly senior leadership roles. And then up to April the 1st, I was the lead for improving patient experience in NHS Improvement and NHS England. So I went with a reorganisation. So getting it right and making it better for patients has always been my thing. And it sounds like it should be second nature to everyone who works for the NHS. And we've heard quite a lot of examples today of ways in which individuals are making that the case. But despite huge efforts really over the last probably 20 years, we're still not quite there. We're not quite where we need to be. And we all know when the pandemic descended, everything needed to be done at huge pace. So lots of things had to change very, very fast and very quickly. And it was really the nature of things that sometimes the needs of patients and the views of patients and really patients' experience got left behind in that whole process of really making very, very rapid change. So we know that care was delayed or moved online, visitors were banished, and then most importantly, staff were moved to lots of new roles. So there was a lot of movement of staff from, redeployed staff from very specialist roles in community, suddenly were running wards and running departments in acute trust. So a lot of change for individuals, patients and staff. So that really resulted in some fairly fundamental psychological changes, both for staff and for patients. And no one could have foreseen that here I would be, at the end of my career, putting on my tin hat and going back onto the front line. So, yeah, it was quite a shock. But I don't think there was really any choice. And I know that Ruth May put the call out and there really wasn't going to be any debate. I remember at the time my husband said, well, didn't we have to discuss this? And I sort of said, well, we could have done, but I'd have still done it because I'm a nurse and that's what you do. So I found myself as a volunteer, a bit rusty, but they did put me through an induction. So I had quite a good refresher from the trust, which was really good. But I was still absolutely terrified to go back on the ward again. The last thing you want is someone who's been a senior manager rolling up her sleeves and trying to have a go. So I absolutely did my best. And I was hugely supported by the team that I got to work with. They were very patient. I'm sure I asked far too many questions, far too much at the time, but they seemed really to embrace the fact that I was doing this really for good reason. So the other thing that I thought about, so I did it. I was working on the ward. I was doing 12-hour shifts, which were absolutely exhausting. So huge amount of respect. Yeah, it gave me an opportunity to really engage with staff And I think in my previous role, what I'd done was I'd gone in, I'd facilitated sessions, I'd worked with boards, but I don't think anything beats actually working alongside point of care team. And as a senior leader who was at the time responsible for making decisions which impacted on those staff through their heads of patient experience, through their heads of nursing, actually it made such a difference understanding what they actually did. So probably in a post-COVID world, because it's really difficult at the minute, but actually that's something I think that senior leaders might want to consider, that, you know, as part of their really gaining understanding of the impact of the decisions that they make nationally or certainly strategically, getting up and alongside staff is a very, very good thing to do, and it really does help you understand. So I certainly did a lot of reflecting as well while I was volunteering. So staff were anxious for lots of reasons. Many were actually self-isolating, so they were away from their families. As I said before, a lot were working outside their normal roles, and they had an increased workload. It was really, really busy. So there was all the faff of putting on your PPE and taking off your PPE as well. So it actually really was difficult for staff. And that was just the staff. So the patients were, as has, you know, been talked about previously in previous presenters' presentations. So it was really isolating for patients, and really, you know, nursing them, I really kind of got a sense of that, and I really felt their sense of isolation. So in a way, the staff had to be visitors and relatives as well as being nurses, and that was really hard sometimes. Particularly dire for people with dementia who had no idea what was going on, and were suddenly kind of ripped away from their familiar environments onto wards that were busy, full of really quite sick people with very busy nurses. And that was really, really difficult. And actually, when you admit somebody, you're absolutely reliant on the relatives to get a really good history. And that's not just a medical history, that's knowing what people's familiarity is. You know, that this is me, principles, you know, putting patients at the centre of things. It's really hard when you don't know what their normal centre is. So that was really, really difficult. And similarly with those with an end of life prognosis. And it was really great to hear that the Royal Free have got a compassionate visiting policy now, because that is so, so important. I mean, relatives were coming in to visit patients at the very, very end of their lives that couldn't be discharged back home. But actually, there were some that were just sort of towards the end of their life, but actually it was a waste of time for them. You know, they were not being with the people that they wanted to be with. So I witnessed acts of real selfless, pure compassion while I was volunteering. But I also saw staff who were absolutely struggling to do that role of of relative as well as of nurses. So that was really, really hard. But there were some great initiatives. So we had great use of technology to connect patients with their loved ones. We had some great medical students that were doing that on the wards. And we also had some other volunteers that were doing that as well. So it wasn't just using iPads and stuff. It was actually using ward phones as well. So that was really good. So this idea about having, you know, I wouldn't have known that had I not have been a volunteer, and I could have read about it and read reviews, but actually being there really made a massive difference. So what have I done? So I've finished my volunteering. As I said, I'm still on the list, so I'm ready to be called up when I'm needed. But since volunteering, I've always had a real interest in this interface between patients and technology, and the impact on patients of use of technology in all sorts of ways. So I supported Healthwatch England, National Voices and Traverse in a piece of work called Doctor Will Zoom You Now, which was really specifically a piece of research on the impact of virtual consultations. So it was interesting, actually, because a lot of organisations are doing work in this area. So I know the Nuffield Trust, the Health Foundation and the Shelfer Group have all done work on virtual consultations, but very little of that work has really focused on the views and experiences of patients. And actually, if we want to know what the impact of non-face-to-face clinical interaction is, actually we've got to involve patients, we've got to listen to their views about it, because otherwise we could fix things in a way that actually has a detrimental effect. So it's just so important that we have ways of listening, and there are ways of listening actually using digital as well. So the other thing that's really struck me through doing that work is digital exclusion. So if you map social exclusion, poverty, health inequality, and the impact on these communities of COVID-19, both physical and economic, there's a significant relationship between all of these factors. If you add into the mix the impact of digital exclusion, we have communities that are disadvantaged. They're not disadvantaged doubly, but quadruply. And so the impact of moving a significant number of services online have a very disproportionate impact on those communities. And for those who are interested in digital exclusion, there's an organisation called the Good Things Foundation that have done some really good research in this area. And I'd urge you to have a look, because it's not the things necessarily you think it would be. So I really urge you to have a look at that. And this has been, it's really fundamental. So there has to be some real work done on really understanding the impact. So I'm not saying all online is bad. We know there's been some massive benefits for people, particularly people with physical disabilities, for example, have really said it's been advantageous not to make arduous journeys into for outpatients appointments. And actually, some people who have mental health problems have found it really beneficial using online therapy sessions, for example. So, but what I am saying is assuming what people's experience is not the same as knowing. And we need to ensure that work on impact, or understanding the impact, needs to include those who use services and those who care for them as well. So we need to look for solutions that have flexibility to meet the needs of individuals, but wherever possible can also offer choice. And that's certainly been the findings of some of that research that's been done. I'm also lucky because I actually am a judge for the Health Service Journal Tech category. And it's interesting because I'm always looking for understanding how technology can enhance the patient experience. But I'm also interested in how patient experience is a routine measure of the impact of technology. So the problem of not doing this is that the implementation of tech to support healthcare can be more about the tech than it is about the patient. So it's just really important that we miss out that negative impact, because unless we have a way of systematically testing it, we might be doing harm and we just won't know. So the principle is wherever improvement's happening, it needs to, wherever possible, include those and involve those who will actually feel the difference. And then our knowing will be robust. So just wanted to put a bit of a plug in for quality. I mean, quality absolutely is a guiding principle for healthcare, and it always has been. But 13 years ago, Aradazi shared his vision in the Next Stage Review. So this is history lessons now. And he said that patient experience should have equal weight with clinical outcomes and safety. So when we're assessing the quality of care, and we're doing that in the context of COVID all the time to fix what works and what doesn't, to turn out what doesn't work. So experience is not something that can be considered in isolation. There is real evidence that considering all three together enhances our ability to understand impacts. So if we don't do that, as I said before, we could be doing harm and we just wouldn't know. So in this world of fast-paced change, we need to ensure that quality and patient experience in quality remains the case. It remains there. And that patients and those who are charged with continuing to deliver care, so that's the staff as well, remain at the centre of decision making. And the last presenter was giving us some great examples of how we can ensure that this happens in a systematic way. Because we know it's not a nice thing to do. It's critical to getting it right. There you
Fantastic. Go. Thank you, Julia, for just a fantastic presentation. In 15 minutes, you've covered so many amazing, brilliant points. I love that you said about, keeping patients at the centre and really putting yourself in their shoes. I don't know if you saw this morning, but Milton Keynes gave a fantastic presentation and they covered many different things that they've done. They've done letters to loved ones, and they really talked about thinking about what it's like for patients not seeing their families. Yeah. And try to solve that by doing that. So they actually discussed that. That will be on video and will be shared on Fab later. But it sounds like COVID really helps you. There's a lot of learning from COVID, from your personal experience. And we've had a few questions in the chat. Julia, what was the organisation? Your voice dropped out.
So I was working for NHS Improvement in England, but I was actually made redundant in April as part of the reorganisation. So I'm actually operating as an independent healthcare consultant. So I'm supporting organisations who want to kind of do all sorts of change management work, but certainly with patients absolutely at the centre. So I
think Phil meant with the digitally exclusion charity you talked about.
Oh yes,
I think that might be the one.
Okay, sorry. Yeah. So so I was working with it was a project that was a partnership between Healthwatch England, National Voices, and Traverse, who are a research, mainly a research agency, but they do other things as well. So I was supporting them with some strategic support and work to broker connections between senior leaders in the NHS. So that's how I came to be working on that project.
Was it called the Good Things Foundation? Is that what?
No, the Good Things Foundation contributed to that work.
Okay.
So they are an independent charity that do quite a lot of the government work. They got a lot of contracts around researching social inclusion, but they do other things as well. But they've just produced some really good data on this area. I just think it's worrying if we don't take notice of it, to be honest.
Yeah, definitely. Has anybody else got anything else they want to say? Any questions for Julia? Brian, have you got any questions? I know that Julia's got another presentation that you're delivering in a minute.
No, I'm aware of that. So no, I was so impressed by your presentation and your enthusiasm for all that you do and in this field. It's so important that patients have champions like you out there shouting for their corner. Thank you so much. That was a great presentation.